The role of anatomy in GERD is critical, and I think that when you look at the history of some of the endoscopic techniques that we've tried in the past, which go back over 20 years, some of the failures that have occurred are probably because we didn't respect the anatomy to the level that we probably should have. And so there's a variety of factors anatomically that are important in reflux. The first, of course, is sort of having the gastroesophageal junction, the junction between the esophagus or the food tube in the chest and the stomach. We would like that junction really to sort of not reside in the chest. It really should be ultimately intra-abdominal. So that's one aspect of it. The second is that there's an angle in the stomach called the angle of His, which sort of becomes less sharp in patients with reflux, and sort of restoring that angle to its proper angulation is essential in helping with sort of maintaining a good barrier between the stomach and the esophagus. And then that additional issue is, again, the presence or absence of a hiatal hernia. A hiatal hernia is a gap in the diaphragm between the crura of the diaphragm where a little bit of the stomach sort of slips into the chest. And what happens is rather than, instead of the diaphragm working in conjunction with the lower esophageal sphincter muscle that helps separate the stomach and the esophagus, sort of a belt and suspenders approach, you now have the belt working against the suspenders. They're actually not aligned. And it turns out fixing the hiatal hernia is a key critical component to solving the issue of reflux. And that's actually one of the big things that we look for in assessing which type of procedure we do, is assessing the size of the hernia in order to determine what the appropriate solutions might be.